Thank you very much for the opportunity to present to you today. I'll be speaking on the topic of the future of training and practice in regional anesthesia. And of course, I will have a slightly United States focused perspective just because that is my experience. I'm currently a professor of anesthesiology, perioperative and pain medicine at Stanford University School of Medicine, and I'm chief of anesthesiology and perioperative care at the Veterans Affairs Palo Alto Healthcare System. You can also follow me on Twitter if you're on Twitter using my handle, which is eMarianoMD. So one of the first things I wanted to talk about was really what is regional anesthesia today? And so when we look at the variety, the breadth and depth of regional anesthesia techniques that we have available now because of ultrasound, there's almost too much to handle. And this is a great graphic from a friend of mine, a consultant anesthetist at Guy's and St. Thomas's NHS Trust in London, Dr. Amit Pawa. And he shows all of the different types of blocks that you can perform for a patient having chest or thoracic surgery. And as you can tell, this is not a simple feat. From anterior to posterior, there are multiple different blocks with multiple different acronyms, some even numbered, that make it very difficult to know what is the right block for any particular patient having this type of surgery. And so the question that I ask, something that I ask often, especially when I'm trying to train either new residents or fellows in regional anesthesia, or even talking to colleagues across the country who are in general anesthesiology practice and interested in trying to offer their patients more regional anesthesia, is it time for us to think a little bit differently? Should we look at the way we train regional anesthesia techniques to the general anesthesiologist? And should we conceptualize a hierarchy, per se, or a ladder of training in regional anesthesia? When we look to this type of a tiered system, I think that it's very important to define what we consider core training in regional anesthesia for all anesthesiologists and differentiate that from what we consider advanced training for regional anesthesiologists who are subspecialists within the core group of anesthesiologists. And then I think it's also important that we consider innovation and what the role is for innovation, because I think while we consider a core set of procedures or part of general anesthesia practice, we don't want to stifle innovation. In other words, we want to make sure that the best and the brightest are still coming up with the next greatest technique, the next greatest regional analgesic approach that may help future patients. And so we don't want to stifle innovation. At the same time, we want to make regional anesthesia more available to every patient. So let's talk first about core training. What does it mean to have core training in regional anesthesia? This is actually a quote from an editorial I had a pleasure to write with my friend, Professor Colin McCartney, who's chair at the University of Ottawa. Regional anesthesia is a vital skill for any anesthesiologist, and ultrasound-guided techniques have enhanced our ability to achieve effective and consistent blocks. It is important that we ensure our graduating residents have the requisite skills to perform basic regional techniques in a safe and effective manner in order to disseminate the benefits of regional anesthesia to the broader surgical population. If we look at the way that we've taught regional anesthesia in the past, oftentimes we refer to what is called the learning curve for regional anesthesia. And what we see, at least in the US-based training system, is that oftentimes what we consider the learning curve is very numerically focused. This is a study that was published in the late 90s from the group at Virginia Mason, and they had looked at the number of attempts it takes to achieve consistency in epidural and spinal blocks. So for a neuraxial block technique, which is different than what we do with ultrasound-guided peripheral nerve blocks, the magic number of 60 comes from this paper. And you can see how this has been extrapolated to many other venues and many other indications, and that this particular set of data really did not account for. If we look at how this has impacted the way that we train residents, at least in the United States, through our Accreditation Council for Graduate Medical Education, the core requirements for any anesthesiology residency program has to ensure that every single candidate, every single trainee can accomplish an experience that includes 40 patients who undergo surgical procedures in whom peripheral nerve blocks are used as part of the anesthetic technique. And I think that the way this has been interpreted in most residency programs in the United States is that every resident has to perform 40 different nerve blocks. But you can see from the writing of the program requirements, and this is actually the most up-to-date version, it actually doesn't say that they have to perform the blocks at all. In fact, I would actually even argue that what was 40 blocks when I was a resident is not the same thing as 40 blocks today. So back when I was a resident, first year in anesthesiology back in 2000, we had the same exact numerical requirement. So for us, for example, if we interpreted this 40 experiences as being 40 different nerve blocks, we didn't have as much on the menu as far as regional anesthesia techniques. I could perhaps have performed a minimum of 4 different types of blocks 10 times each, and then argue that I've achieved my minimum requirements for regional anesthesia training in peripheral nerve blockade. Now today, because of ultrasound, we have so many different types of nerve blocks. We have so many different fascial planes in which we can inject local anesthetic that it is realistic that you could perform 40 different types of regional anesthetic techniques one time and still achieve the same minimum level of case log requirements for peripheral nerve block experiences. So one of the arguments that two of my colleagues, Dr. Lloyd Turbot and Dr. Fareem El-Baghdadli, had argued in one of our editorials for anesthesia was, should we redefine what we consider basic regional anesthesia? And our editorial title, Future Directions, really argued that perhaps it's more important to try to simplify what we teach in terms of regional anesthesia to make it more accessible to all. Should we look at select high-value nerve blocks as a type of core set of blocks, or what Regional Anesthesia UK is referred to as the Plan A blocks, so that way we can disseminate widespread competence and then improve implementation of regional anesthesia into routine clinical care such that more patients actually have access to regional anesthesia. And I would argue yes. I think every anesthesiologist in practice should be able to perform a certain set of core types of nerve blocks. And this just makes regional anesthesia much more accessible and available for patients having common surgeries. Now, the set of blocks, or what you include in your list of Plan A blocks, can vary based on practice, based on environment, based on patient population, based on the hospital in which you work, because you may not see all of these different surgeries. But we believe that a general anesthesiologist who finishes core training in anesthesia should be able to perform a nerve block for shoulder surgery, a nerve block for distal upper extremity surgery, some nerve block for hip and knee surgery, a block for foot and ankle surgery, and then some block or more than one block for either chest wall surgery and also abdominal surgery. I think if you can do this, and this is already in the 99th percentile of nerve block training for general anesthesiologists. But I think it's also important for us to really focus now that we have well-established techniques using ultrasound, that we really focus the training for our trainees in anesthesia such that we can produce more competent general anesthesiologists who can perform regional anesthesia for their patients in the future. So now let's talk a little bit more about advanced training. So what does that look like? If we've established a core group of blocks for every anesthesiologist, what do subspecialists in regional anesthesia have to know? And the concept of subspecialization is not new, and it's not restricted just to medicine. If you read the writings of Malcolm Gladwell, one of the concepts that he has is this 10,000 hours rule. So the 10,000 hours rule says that if you look at any kind of cognitively complex field, from playing chess to being a neurosurgeon, we see this incredibly consistent pattern that you cannot be good at that unless you practice for 10,000 hours, which is roughly 10 years, if you think about 4 hours a day. Now, perhaps this is not exactly true for every discipline, but I can tell you that having performed nerve blockade repeatedly for the last, let's say, almost 16 years, that over time, you start to develop expertise. Now, one of the concepts that we have had, at least here in the United States, is really tracking the evolution of regional anesthesia training as fellowship training. And this has evolved, as you can imagine, a great deal over the last several years. And initially in the 1980s and early 1990s, there were only select programs in the United States that offered this subspecialty training, which is post-anesthesiology residency. So after finishing your core residency in anesthesiology, this was an extra set of training, either in several months, even up to a year, in which you would subspecialize in regional anesthesia. And the format of these early regional anesthesiology fellowships were primarily apprenticeships. And they were locations, they're specialty hospitals that focused on regional anesthesia. They had a core group of experts who had either learned from others or trained themselves and commonly practiced regional anesthesia for their surgical patients. Over the years, as you can imagine, the growing number of fellowships demanded the need to standardize how fellows in regional anesthesia and acute pain medicine were trained, to the point where the organization, the Fellowship Directors Group for Regional Anesthesia and Acute Pain Medicine in North America, started in 2002. It's still an informal group. It meets twice a year, and several initiatives have come out of this particular group. Voluntarily, this group started developing its own guidelines for fellowship training in regional anesthesia, which have now been formalized as part of the ACGME Common Program Requirements for Regional Anesthesiology and Acute Pain Medicine. It developed practice sharing techniques and knowledge sharing to the point where we created a common question bank for fellows who are training in regional anesthesia that all fellowship directors could use. We also created a common application, which was initiated by Dr. Brian Allen, who's at Vanderbilt University, in order to make it easier for applicants to regional anesthesiology and acute pain medicine fellowships to fill out their application information and submit it to programs. Over the course of 5 years, give or take, I led this task force that actually sought and achieved accreditation for regional anesthesiology and acute pain medicine fellowships. And what this meant and what it entailed for us in the United States was actually submitting a request to ACGME to be considered as a subspecialty of anesthesiology. We had to justify how the training in a fellowship for regional anesthesia would be different than the core training in regional anesthesia for a resident. It also required that we created common guidelines for fellowship training in regional anesthesia that covered all of the core competencies: medical knowledge, patient care, interpersonal communication, practice-based learning and improvement, and also required that there was some sort of an external review of programs that apply for accreditation, as well as ongoing review of accredited programs to ensure that they're still meeting the requirements of an ACGME accredited program. This process, which you can read in much more detail, is included in this article that I wrote with Dr. Rick Rosenquist. This process, I think, of standardizing the training really means that the products of regional anesthesia fellowships, or the graduates, the subspecialists in regional anesthesiology and acute pain medicine, can be considered true experts who have been trained and fulfill the program that is subject to external review. And anyone who hires these fellowship graduates knows what type of training, subspecialty skill that person has at their disposal for patient care. So today, when I look at where we were, at least at the end of 2020, we know that there are 87 fellowships now in regional anesthesiology and acute pain medicine in the United States and Canada. This is up 3 programs from the prior year. And we also now have over 200 positions available across North America. Of these programs, we now have 35 programs that are approved by the ACGME that are accredited. And even of these programs that were accredited initially in 2017, and now we have 15 programs that have achieved continued accreditation. This means that they not only were approved for accreditation back in 2017, but they've already had their required 2-year review, which is performed externally by the ACGME through a site reviewer. And they've passed and been demonstrated to have achieved and continued to maintain the requirements of an ACGME accredited fellowship. So lastly, let's just talk about innovation and what that looks like in the future of regional anesthesia training. When we talk about what we consider the innovation in training in regional anesthesia, much of what we tend to discuss is technology focused. One of the most basic ways that we train regional anesthesia today is in the use of simulation. And I think one thing that we have learned, at least in our studies of education and training in regional anesthesia, is that it is not enough to train an anesthesiologist who's trying to learn an advanced regional anesthesia skill in just hands-on scanning and practice on a gel phantom. That is not sufficient training in order to perform a real-life advanced skill like continuous peripheral nerve block for an actual patient. What we have found is that when you take the basic elements of regional anesthesia training that you would commonly find in a workshop, like didactics, phantom scanning, scanning nerves in a live model, and you add onto that the practical hands-on experience of actually performing the procedure with a facilitator who can provide you real-time feedback, then your skill level increases. And you can see at the end of a day in which we've added on this hands-on practical scanning with iterative feedback on top of what we consider a normal didactic and hands-on workshop, it, those participants, after one day, can perform an advanced skill like continuous peripheral nerve blockade or perineural catheter insertion. If we look a little bit further and try to look at other tools available to us, because the COVID-19 pandemic has really changed our ability to offer many of our hands-on workshops, I think that knowing what's available online and easily accessible is key. This is a fantastic educational tool. If you look at this site, this is offered by the University of Toronto. They have a virtual reality simulation model. This is the spine one that I'm showing you here, but it allows you to really remove various layers. You can rotate, you can change your perspective on trying to understand anatomy. And you can also layer on what you would envision as the layers you'd see under ultrasound. They have a few different other anatomic models in addition to the spine, but I think this is a great educational resource, which is available completely free and can be used for just-in-time teaching, as well as for pre-work for many of your trainees who are trying to learn regional anesthesia techniques and at the bedside or online prior to engaging in patient care. Another interesting technological advance from the University of Toronto is the application of hand motion analysis, which is something that's been studied in surgeons. One of the ways that we struggle, especially with our trainees, is in the assessment of competence. So how do we know whether a trainee has achieved a certain level of competence with a particular procedure? Now, oftentimes we use numbers. So in our case, in the ACGME requirements for residents, they have a minimum number of cases they have to have performed. Sometimes we have a delineation based on time. So you have to spend 2 weeks or 4 weeks on a specific rotation in order to have achieved the learning objectives for that particular rotation. Using more objective outcomes, in this case, hand motion analysis, can help determine when a procedural performer, has achieved a level of comfort performing a procedure. And as you can imagine, which seems somewhat intuitive, that once you become an expert, you actually decrease the amount of hand motion. So you have much more conservation of movement compared to a novice. Another technological tool that we've used in our practice is the use of eye tracking. So being able to see what the user sees. And as you can see from just this side-by-side image, A actually demonstrates an expert's eye tracking performing a simulated thoracic paravertebral block in a mannequin. If you look on the right, this is a novice who's actually never performed a thoracic paravertebral block in a live patient. And you can see that from the heat map that the gaze fixations are all over the place compared to the expert on the left. The other thing that I think is important for us to consider for the future of training, and this goes into the educational innovation aspect, is that not every learner will learn the same way. This is a really interesting study that looked at this concept of mental rotation testing as basically a pre-test to determine which participants would be more facile with learning ultrasound-guided regional anesthesia. And not surprisingly, there was a correlation between those participants who scored highly on a mental rotation test and their ability to learn regional anesthesia using ultrasound. So perhaps not everyone who learns regional anesthesia is the same, and perhaps we need to individualize the way that we teach and the way that we assess competence in regional anesthesia going into the future. You can read a little bit more about my feelings about shared education online. I mentioned that I am active on Twitter. I do think that it's important that we look at social media as an educational resource. This is an innovation. It's a good way for new learners to have access to experts, as well as find a curated form of online information from people who are actually interested and also engaged in research in that particular field. I think it's also important that we look at pragmatic ways to evaluate new techniques. So not every new block that you read about in the latest journal is going to be the latest and greatest block. I do think it's very important for us, especially if we have established regional anesthesia techniques we already use in our practice, that we consider these four basic categories: improving outcomes, enhancing efficiency, access to care, and decreasing disparities in care, especially where it pertains to pain management, when we're trying to decide whether we replace a technique that we already do with a new technique that we've read about in a journal. And I think one practical way to apply these criteria is to assign a point system. And this point system, of course, would differ based on your type of practice and what you consider very important. But as you can imagine, if you have a total of 100 points and you spread out your points across those four criteria, then it allows you to score one block versus another block, or a new block versus an incumbent block, to decide whether or not it makes sense for you to even trial something different in consideration of updating your regional anesthesia protocol or your clinical pathway for multimodal analgesia. So in summary, we discussed the future of training in regional anesthesia by discussing and defining what should be core training for all anesthesiologists in regional anesthesia. And then we explained what advanced training or fellowship training in regional anesthesiology and acute pain medicine should look like, using the example of ACGME accredited fellowship programs within the US. And then we talked about innovation in training regional anesthesia and the use of technology and objective assessment tools to try to determine competence in regional anesthesia. And perhaps the future of training in regional anesthesia will be much more individualized based on the aptitude of the learner, as well as objective criteria that can determine when a learner can move on to the next step in core training and then eventually in advanced training in regional anesthesia. Thank you again for the opportunity to speak to you.